Debbie, can you confirm that that looks okay?
Yep, it looks great.
Awesome. Doing it all from my laptop today, so I don't only have the one screen. So it makes it a little more challenging. But we'll get started. Thank you everyone for joining us today for our next Quality Cafe. This is actually session 5. We're going to be learning a little bit about sepsis and how to improve our sepsis through leadership engagement. And I have a special guest I'll introduce in a little bit. Just as a little reminder or overview, our quality cafes are 20 to 30 minutes of learning with a Q&A session after that. Anyone that's interested can join. And the goal is to foster networking and shared learning amongst our quality professionals here in Alaska. We're currently meeting every 2 months. This was supposed to be our April meeting, but with scheduling, we ended up at the end of March. We got a lot going on in April. We've, like I said, had 4 other sessions. These are the titles and the dates. If anyone wants the recordings from these sessions, just let Debbie or myself know when we can get them sent to you. We are working on a quality section of our new website with AHHA, and we hopefully will have a way that people can just go in and grab them directly themselves. But for now, if you want one of these recordings, just reach out and let us know. So I just wanted to give a little overview of sepsis mortality and where we are kind of in the state of Alaska. So as we probably most of us on this call already know that sepsis is a leading cause of death in US hospitals. It's also a leading cause of readmissions to these hospitals. Up to 19% of people originally hospitalized with sepsis are rehospitalized within 30 days. So Alaska hospitals participating in the AHHA Telegen have demonstrated a consistent downward trend in sepsis mortality since August of 21. So you can see we had this spike back here, but in August of 21, we've been bringing that trend down, which is awesome. Facilities have reported that increasing leadership involvement through sepsis committees and councils and increasing compliance with sepsis bundles through their provider education and engagement has helped bring this metric in the right direction. So with that, I'm going to turn this meeting over to Rachel Kincaid. She is the Chief Nursing Officer at South Peninsula Hospital, and she's going to share her presentation that she gave at Telegen's Unite Against Sepsis campaign meeting earlier on in the year. So Rachel, I'm going to let you speak.
Thank you, Kristen, and thank you to the AHHA team. I have been sharing a very similar presentation with anyone who's interested over our journey here at South Peninsula Hospital in Homer, Alaska, over the last 2 years. As Kristen explained, I'm the Chief Nursing Officer and I'm the Long-Term Care Administrator. We're co-located, and so I'll try to speak to both patient and resident populations, but this was designed to really go after our ER and acute care inpatient population in terms of sepsis improvement. You can advance the slide, Kristen. So for those who don't know what a critical access designation means, or for those of you that just kind of have heard us referenced as critical access, if you're like me, I'm from a very large area, Charlotte, North Carolina, lots of teaching hospitals. I've never worked in a rural or critical access environment before 2020. So it's really nice for me to kind of refresh my own education on this. We, per our designation, are not to have more than 25 licensed beds for inpatient. You have to be at least 35 miles away from the nearest healthcare facility. Central Peninsula is 75 miles north of us. We do have a level 4 trauma designation where we're able to stabilize folks with trauma and then usually ship them north or even down to Seattle. And then the last is our average length of stay over the course of a year needs to be 96 hours or fewer. In terms of our area in Homer, our service area is about 15,000 people. And then I like to kind of paint a picture of what our building looks like and who's coming in for care. We do have a 9-bed ER. We have 2 operating room suites with full-time general surgery and orthopedic surgery. We are co-located, like I referenced, with a 28-bed long-term care facility, all of our residents are long-term care level of care. So we're licensed for SNF, but we aren't providing short-term rehab and short-term stays. Most of our folks are with us for life, and nearly all of them have a cognitive impairment, and are typically your what you picture when you picture elders with dementia. That's our general population there. And then in our acute care setting, we have ICU beds and OB beds. We're not going to talk about OB sepsis today, but 18 actual acute care beds on the wing. Our general area, our campus, is very spread out over about 1 to 2 miles. We would love to have a medical office building someday, but for now, we're doing a lot of property purchasing and renting. And we do provide, as you can see on this list, a wide array of primary care services and preventive services in order to keep our patients right where they are in Homer, Alaska. Next slide, please. So one of the questions I was asked in the Telegen call was how we engage senior leadership in our sepsis committee work. That's me as well as a senior leader. So it was a really cool question. I do like to think of myself a little uniquely in terms of I am a registered nurse, but I'm also an advanced practice nurse. So I started my career here as the nurse practitioner in the long-term care facility. So I do have just a different clinical perspective in terms of working up and treating a patient for sepsis. And I would say that combined with our CMO, adding a CMO to our senior leadership team, Dr. Christy Tuwami, has helped in terms of the clinical approach. Also, our CEO, Ryan Smith, is very interested in sepsis. He's interested in any publicly reported data measure. He loves looking at Care Compare. He loves challenging us to work on quality initiatives. He brings it up in every senior leadership meeting. He reports it to the board every month and asks each senior leader to speak to their own publicly reported data. But we actually, just to be completely frank and vulnerable, we lost an employee to complications of sepsis in January of 22. And he was young. And when we were able to really do a full review, root cause analysis, what have you, in terms of like the Swiss cheese methodology of preventing bad outcomes, there were just obvious areas in which we could improve, as evidenced by our Care Compare sepsis scores at the time. In our quality department, led by Sue Shover, who I believe is on this call, did such a great job of tracking our data and identifying areas in which we needed to improve. But at that time, there just wasn't the momentum and the initiative and the sense of urgency, I think she would say, in terms of what a steering committee was supposed to do. And so she and I kind of partnered together at that time and started gathering every single week for almost a year. And so I would say that just like showing up, the mundane, sometimes repetitive, frustrating work of auditing charts and just ruthlessly asking ourselves over and over again, the concept of why did this happen? Why did this happen? With any sepsis case that fell out of the measure, I think that's really what triggered our improvement process and made us better. So now we have a more traditional form of a sepsis committee. And like I said, both the CNO, myself, and the CMO attend, which helps with clinical championship. And then we report our sepsis statistics every week to our senior leadership team. And then every month I speak on that topic in tandem with our quality team and Sue to our board of directors. You can advance the slide, Kristen. How do you keep your sepsis committee organized, including goal setting and engaging multidisciplinary team members? So when we started meeting weekly, I went in person and asked each department to attend. And so where previously they had kind of been coming and going, I feel like we really made it a priority that every single department that touches sepsis workup or treatment needed to be present as a stakeholder. So we had folks from pharmacy and lab and acute care and ER, obviously. We started inviting members of the surgery team, because surprisingly, a lot of our cases tend to show up with like a typical post-op involvement. And I don't say a lot of our cases. Some of our cases that are harder to track show up with a typical surgery and in the post-operative phase on acute care is when they start to develop symptoms. And so you've got to have that surgical involvement there. And at the end of our meetings, which are now our infection prevention nurse, Anna Leewald, she runs through all the cases that we've reviewed for the last week or month or however often we're meeting. And then she makes each party kind of give a roundtable input, which I love. So she'll say, pharmacy, what's new in your area? What are you seeing? What are you reading in terms of research or best practice, or even here at South Peninsula Hospital? What do we need to improve on? And I think that really creates an open sense of dialogue, but also accountability, to make sure that they know that we expect them to show up and participate in a hospital-wide initiative to improve our sepsis care. Additionally, our statistics are reviewed in managers' meetings and other non-clinical areas where we want to educate people on what we care about, just like our clinical teams are learning about finance measures or MIPS data that is now, publicly reported and tracked. We really feel like it's part of our strategic plan as a hospital to care about a few, 5 actually core elements, and we talk about those elements in pretty much every area of our connectivity. And so those elements are clinical quality and safety, employee satisfaction, patient and resident satisfaction, medical staff alignment, and finance. So we try to run every meeting and opportunity to connect through that agenda. And that's why sepsis pops up so often in non-clinical conversations. Next slide, please. Significant challenges that we faced related to engaging leaders in sepsis work. Yes, we have found challenges, as I'm sure all of you have if you're doing this work. One, I'm sure you've all heard from someone before that the best practice as defined by CMS is not always up to date or caught up with the research. An example would be the way that we talk about ideal body weight and calculating IV fluid rate. Another example would be procalcitonin. We love to look at procalcitonin as an indicator for early sepsis, but it is not part of the measure in the same way that lactate is. And so when you start talking to physicians or APPs about whether or not to include certain elements in their workup, you might hear, well, that's not how I practice, or that doesn't change the outcome for the patient. And those things might be true. But what we have found is that when you press through and you invite them to buy in by saying things like, you're right, but we have a duty of obedience to what CMS mandates for us. And in order to do that and make sure that the patient has the best outcome, why not include both, or that sort of thing? It's also really easy or easier to sit in a group and track through a chart and understand what a physician or a nurse meant when they documented something. It's significantly more challenging to do that weeks or months later, and also one-on-one with just you in a chart, which is why we value that in-person meeting so much, and also why we value doing it in a timely way. Next slide, please. How has leadership engagement and outreach to multidisciplinary partners positively impacted your sepsis work? So I'm going to show you our academic poster that we've presented a little bit in the last quarter or so. But our scores showed improvement, significant improvement. We went from hanging out in the 90s to over 90% of our severe sepsis and septic shock cases meeting the measure as defined by CMS. We also feel like moving our meetings to more regular intervals and also assigning specific people to specific chart abstraction and review work. That led to a sense of urgency and timeliness. It feels much better to go see a doctor or a nurse the day after they make a decision and say, hey, did you know that? Or great job when you da-da-da-da-da, rather than weeks or months later. And then lastly, it feels really good to win. Like, it feels really good to set a goal and meet it. It feels good to see your scores improve on a publicly reported scorecard. And so we have begun conversations in terms of incentivizing our scorecard, the way that we talk about the projects that we care about organization-wide. We have started to explore what it would look like to even financially incentivize those. I'm sure if you're a nurse, you have worked somewhere where you were given a pizza party or something when people went, a unit went 60 days without a fall. And so I don't want it to feel cheesy or trite, like we're talking about human lives and improving care and quality outcomes, but it also feels really good to really unite behind an initiative and then see progress with it. So we have begun exploring, just talking about, like, what would that look like to incentivize items that we care about with our staff. Next slide, please. So these are the 5 elements of our strategic plan that I told you about earlier. And it does relate to sepsis because these are the things I put everywhere on every communication. We have a nurse leadership meeting that meets regularly, and I open the meeting by reading these aloud because I really feel like when you change the language, you change the culture. When you tell people what you care about over and over and over again, it becomes intrinsic to them. And so we will put, like I referenced, a sepsis update under that clinical excellence and service regularly. And now our staff, our community members, our board members are sort of trained to ask us, like, how are things going with sepsis? What do you guys have to report on sepsis? And so I highly recommend that socialization of those themes and those projects as a way to really invite more input and support as you're working on process improvement. Next slide, please. This is our academic poster. I would like just to use my last couple of minutes to share the actual methods that we use to improve our sepsis scores. I know people want to hear like line by line what we did. The CDC core bundle that we sort of helped present on about a month or 2 ago now with the Telegen call. That is an amazing resource. It only came out recently. We kind of hodgepodged it ourselves before it was formally introduced, but I would highly recommend that as a resource. Our methods looked very homegrown and tedious and difficult in terms of every single day, our infection prevention nurse, now one of our nurses in our quality team, and myself, every single day we get an alert in our EMR on anyone in the hospital who has triggered for a sepsis or SIRS criteria. So that's a lot of charts to look through. And I don't have a way to automate that. We are not on Epic. We are on CPSI Evident. And I have been told that maybe Epic has some tools to help with this. We are converting to Epic in 2025. But for now, showing up in an interdisciplinary committee every week or every 2 weeks or every month, whatever you need, followed by just tedious, relentless chart reviews at the beginning, so that you can get a feel for how often your patient population is triggering. So that means ER and acute care patients who have a significant vital sign change, who have a significant lab change, or whose provider has documented something like infection in some ICD-10 code somewhere, tends to come to our inbox as an alert. And we keep a shared spreadsheet where we have the CMS measure for severe sepsis and severe septic shock management, and each column has, the lactate. When were the blood cultures drawn? When was the antibiotic ordered? When was the antibiotic given? When did the provider document perfusion reassessment? All of that. And we just go through and we blitz it every single time. So I know that our patient population might be significantly smaller than some of you. We're averaging right now somewhere around 100 ER visits a week. And in the summer, it will probably triple. Same with our acute care. We might only have 10 to 15 patients, but sometimes we have a full house, depending on the time of year. And so we will review each of those cases. And if they were seen in the ER for, say, a dislocated shoulder or something, and that's why their heart rate spiked, or they had a fever because of some unrelated cause, then we just throw them out. But if it looks like it's headed towards sepsis or severe sepsis or shock, then we follow it. And so that's the magic sauce, is just staying on top of those patients and then going physically to those departments and assisting the team to properly do the workup and the follow-up, which took about a year. We're in year 2.5 now. And now it feels a lot more comfortable and familiar to our staff. But at the beginning, it was a lot of right at the elbow kind of support. So I would say that was one. The other was the nurse-driven protocol that our physicians agreed upon, which means that by the time a nurse calls a physician and says, I'm concerned for sepsis, they have already initiated a nurse-driven order set that allows for the proper workup in the proper timeline, which means blood cultures are already pending, lactate has already been drawn, then we can start IV fluids and antibiotics at the proper time. I think those were probably the main elements to our protocol. The last thing I would say is that our physician champions really owned this process. They each, ER, surgery, and acute care, each agreed on a template on how they would document their workup and their treatment of sepsis patients, so that we, when we are chart reviewing, can kind of follow their thinking. And that allows for much closer analysis and also follow-up if they're missing something. And as you can see, by Q1 of 2023, we had climbed to about 90%. We actually hit 100% in Q4 of this past year. And now every time we have a fail or a fallout, we're able to very quickly address it. Every patient has received excellent care. The outcomes have been great, but we've been able to follow up and say, you know, the lactate could have been drawn a little bit closer, and now we're going to fall out when we report to CMS. And our providers and our nurses are so much more appreciative of that feedback in real time. I think that's it. Kristen, do I have any more slides?
I don't think so.
Cool.
I did want to ask you, how many sepsis patients on average do you have a month or annually?
Great question. We look at probably 4 to 6 cases a week. And we've noticed a trend over the last year where we're seeing fewer and fewer actually get to that severe sepsis and septic shock, probably because of our, you know, early intervention. So very rarely now do we actually have a full-on septic shock case. One a month, a couple a quarter, but we'll look at, you know, anywhere from, like, we're having a slow month right now. We'll look at 3 to 4 a week, sometimes as many as 10 or 12 in a week that might have sepsis or might have an infection. And just to get our team familiar and comfortable with the protocol, we still chart review them all the way through as if they had severe sepsis or septic shock. Did that make sense? Just to kind of
Yes.
get our reps in and make sure we understand the language that we're speaking.
Absolutely. And then a question about the nursing, nurse-driven protocols. Is
Yeah.
fluid resuscitation part of that, or does the doctor?
The physician orders that. We make the recommendation. Would you like to order at a rate of 30 mils per kilogram? Or would you like to document against that in the presence of heart failure or fluid overload or whatever the exceptions are? So we have language to kind of coach them through that, because a lot of times the provider will answer the phone and be like, what do you think I should do? You know, like, what have you assessed? What do you recommend? And to have that protocol is really helpful to recommend.
Awesome. Before we move on to my final slides, does anyone have any questions for Rachel?
I don't have any questions. This is Mary in Kotzebue, but awesome job, Rachel.
Hey, Mary, thank you so much. That's my mentor right there. So if she's proud of me, then it's a good
Girl,
day.
I'm beyond proud.
We've actually, speaking of elder care, we've seen a spike in our residents with triggering for sepsis, almost at the same rate of some of our ER patients and acute care patients. Because our elders are in an outpatient setting, they're not going to be reported to CMS in the same way. But what we've done is duplicate our protocol, and specifically the nursing guide, like decision-making guide for the nurses. I mean, you know, if you've got a relatively new nurse on a night shift at 2 a.m. with an elder who spikes a temp, if he or she is considering sepsis in the presence of all the other conditions, like, then we've done our job. And we have seen that as well. A lot of nurses on long-term care will call the medical director and say, or our nurse practitioner, and say, I recommend this, this, and this. What do you think? And that's even more complex in an elder with, you know, comorbidities. But we're kind of replicating that in a little bit more of an outpatient setting, and it seems to be working.
Awesome. I know people are going to ask, so if you could share that nurse-driven protocol with me, we'll
Absolutely.
add it to our resources.
I will send it to you
And
after
then-
this.
Thank you, Rachel.
Yeah.
Any other questions for Rachel, or anyone want to update what they're doing in their facility?
So
Open the floor
Kristen,
for a minute.
this
go ahead,
is
Sue.
Sue, and I just wanted to thank Rachel. She did a great job, and she has really been a catalyst to help move the needle here at South Peninsula Hospital. So making sure you have champions that will help move it. When she spoke of years ago how, you know, it was hard to get people motivated because we just didn't have the champions to drive it. And we have a really good leadership team who really sees the value and knows the importance, and they really make a huge difference. I've seen our numbers just go in the right direction, and I'm really proud of the team.
You guys are doing good work
Sue.
over there. Rachel mentioned a bunch of these resources, but these are all hyperlinks. So when we send out the slides to everyone, you'll get this. But this sepsis call to action series was that 6-part series that many of the hospitals participated in November into December. The CDC core elements that Rachel mentioned. I linked the Surviving Sepsis campaign in because there's a lot of great information in there. And the Sepsis Alliance is an amazing website. You have to register to use a lot of the resources, but it's free and they have amazing educations and everything in there. And then Telegen has one more session, April 17th. It actually is engaging patients and families. Is the topic. So I encourage people to click on that and register for April 17th. As we get those recordings from those Telegen United Against Sepsis series, we can add those to the resources as well. Any other ones that I might have missed, Rachel?
No, these are all excellent. It's one of those things that's just like, it's very basic. It's just incredibly complicated and time sensitive. And then you've got all these different interdisciplinary people that you have to get to buy in to function as a team. It's, it's not as easy as MI symptoms and making sure that we get an EKG within 10 minutes. Like, it's just very black and white. And this is so nebulous in a way, but I really love these resources because they spell it out. It's just a matter of getting people to buy in.
Absolutely. And that concludes our session for today. Our next session will be in June, date to be determined, as well as the topic. So if you have an idea of a topic you'd like to see presented or something you would like to share with the group, please add that in. There's going to be a quick survey when you exit the Zoom meeting. If you could add it to there, or just let Debbie and I know if you have something you'd like to be shared. Does anyone have anything else before we close? You're welcome to put it in chat or on mute and holler it out. Well, awesome. I just want to say thank you to Rachel for being willing to share this wonderful work with all of us. It was great to hear you speak.
Thanks for having me.